It's a pleasure to introduce our wonderful keynote speaker for today. It's Dr. Julie Gralow. She's the Chief Medical Officer and Executive Vice President of the American Society of Clinical Oncology, ASCO. Prior to assuming that role, she had a career as a breast medical oncologist and professor of global health for 25 years at the University of Washington in Seattle. Today, Dr. Gralow is going to talk to us about breast cancer care and control across the continuum, strategies for optimizing outcomes. Julie, we're very happy to have you with us. Thank you so much, and please go ahead and welcome.
Thank you so much, Rola. Thank you for the invitation for speaking. I'm very sorry I can't be there in person, but I'm hoping soon with the pandemic winding down that international travel will be allowed again. I'm excited to talk to you about breast cancer care and control across the continuum, strategies for optimizing outcomes. Let's start with the global perspective of cancer. Cancer really made it on the global agenda back in about 2011 when the UN held its first high-level meeting on the prevention and control of non-communicable diseases. It was determined that NCDs, non-communicable diseases, were a major challenge to health and development for the 21st century. And it was known that the four main non-communicable diseases, cancer, cardiac disease, respiratory disease, and diabetes, kill 3 in 5 people worldwide. So about 10 years ago, NCDs became a priority for the UN. And with that, the World Health Assembly actually specifically targeted cancer in 2017 with a cancer resolution called Cancer Prevention and Control in the context of an integrated approach. On this slide, it shows a conclusion of that resolution that there are 4 key drivers for impacting cancer mortality by 2025, and they're really applicable to breast cancer as well as all cancers. So number 1 key driver is early diagnosis. Now, they called out cervical, breast, colorectal, and oral cancers, and specifically stated that early diagnosis is not going to improve survival unless it's coupled with effective treatment. So early diagnosis is key, but it does nothing unless you tie it to treatment. And number 2 key driver is development of partnerships, referral networks, and centers of excellence for improving quality of cancer diagnosis, treatment, and care. And that has to include multidisciplinary cooperation. They specifically state that determining optimal treatment relies on accurate diagnosis, high-quality pathology and imaging, and multidisciplinary care provides the best outcome. Key driver number 3 is the training of health professionals across all levels of healthcare. And while barriers to cancer treatment involve the costs of equipment and drugs, another barrier is an educated workforce to deliver that treatment. And key driver number 4 is that strengthening palliative care and promoting cancer survivorship, follow-up, and rehabilitation is key. So optimal care includes addressing the short and long-term toxicities and optimizing a patient's quality of life. So we need to keep this in mind across all cancer, as well as specifically when we're addressing outcomes in breast cancer. So with respect to breast cancer, it's clear that reliable data is needed to understand the magnitude of the cancer burden and the potential impact of any interventions we provide. And this is from the GlobalCan 2020 data, the most recent data from the International Agency on Research in Cancer, showing the most common cause of cancer in females. On the left is incidence, on the right is mortality. So the world looks pretty pink, which is breast cancer as the most common cause of cancer in females globally, but cervical cancer is the most common cancer in some cancers. And then with respect to mortality, pink again shown here is breast cancer, while lung cancer in Canada, the US, certain parts of the world has surpassed breast cancer as the leading cause of death, and other cancers are the leading cause in a few countries. Now, I was fortunate to be part of a global task force on cancer care and control that was coordinated out of Harvard for many years. And we published a report called Closing the Cancer Divide: An Equity Imperative. And I just want to make a few key points that are general across cancer, and then we'll delve into breast cancer. So the Global Task Force stated that we need to improve awareness of breast cancer as a curable disease. We need to integrate early detection programs into maternal child health, sexual and reproductive health, and HIV/AIDS programs. We need to augment cancer registries and data collection. We need to increase early detection. Metastatic disease is not treated successfully in any country. We need to tailor therapy to the individual cancer and the individual patient. We need to develop economically feasible and culturally appropriate guidelines and convert those into pathways that we follow. And then we need to promote public advocacy for breast cancer prevention, detection, treatment, and research. So I wanted to talk about breast cancer care and control across the continuum that starts with prevention and risk reduction, moves on to screening and early detection, then diagnosis, treatment, survivorship, and palliation. You'll be interested to know that the WHO has launched a breast cancer initiative called the Global Breast Cancer Initiative just this past year, and it's led by my colleague, Dr. Ben Anderson, a breast surgical oncologist. The goal behind this is to empower women, build capacity, and provide care for all. And there are three main pillars of action. Pillar one, which they're calling the patient interval, is health promotion and early diagnosis. Pillar two is timely breast cancer diagnostics. And pillar three is comprehensive breast cancer management. I'll go into the goals of those as I discuss the continuum. So under prevention and risk reduction, understanding a patient's risk of developing breast cancer is the key to best determine how to reduce her risk. And IARC and Global Plan 2020 have stated that in looking at the global increases in breast cancer, they're likely due to marked changes in lifestyle, sociocultural contexts, and environments in many countries. And these include changes in delayed childbearing, having fewer children, increasing overweight and obesity, poor diet, and decreasing physical activity. So if we're going to address breast cancer risk reduction, we need to understand what's causing increased breast cancer globally. Now, I'm going to give you a few examples of innovative delivery in cancer prevention and awareness. And the first is something that the Global Task Force called out. We need to integrate health promotion activities. And this is an example of integrating health promotion and cancer education and awareness into anti-poverty and social welfare programs. The picture shows breast and cervical health training with HIV community health workers in a MENA village in northern Uganda. And they're promoting HIV and AIDS treatment and awareness, but also they've been taught about HPV vaccination related to cervical cancer and incorporating it into adolescent sexual and reproductive health and HIV/AIDS programs. And these health workers are promoting breast self-awareness, healthy lifestyles, breast cancer early detection, and early reporting of symptoms and screening where it's available. Another example of innovative delivery in breast cancer prevention and awareness is integration of health promotion activities into the primary care level. And this is a picture in Mexico City of training health promoters, nurses, and primary care doctors to perform clinical breast exam and counsel patients about cancer risk reduction strategies. And then a third example of strategies for improving breast cancer outcomes through integration with patients and improving awareness of breast cancer as a curable disease. It's key in countries like Uganda, where we held focus groups asking about knowledge and attitudes to convince these women to come in early if they feel a lump or a breast abnormality And what we found in many countries and through such focus groups is that not a single patient here, not a single woman reporting to a just community health clinic knew a cancer survivor. And so in Uganda, we partnered with a group of cancer survivors, the Uganda Women's Cancer Support Organization, to show women in their community that there are cancer survivors and to discuss the importance of presenting early when you find a breast abnormality. Now, moving along on the continuum is screening and early detection. And I previously stated that we need to increase early detection of breast cancer. The UN's World Health Assembly in 2017 resolution made a strong statement that early diagnosis and prompt and appropriate treatment can reduce mortality and improve outcomes and quality of life of cancer patients. So if we go to that WHO Global Breast Cancer Initiative, I told you the first pillar was health promotion and early diagnosis. And here the goal they're aiming for is to achieve diagnosis of at least 60% of invasive breast cancer at stages 1 or 2. So in order to know where you are, you of course need accurate data and registries, but the goal here is through early detection and screening where available to increase the number of early stage breast cancers diagnosed. And this is just another picture from Uganda on increasing early detection. This is an example of community events coordinated by the Uganda Cancer Institute teaching about breast self-awareness and breast self-exam. Now, with respect to diagnosis, you have many talks in this wonderful conference about accurate cancer diagnosis, which is key to determining an appropriate and successful treatment plan. The second pillar of the WHO's Global Breast Cancer Initiative is timely access to diagnostics and evaluation, imaging, tissue sampling, and pathology should be completed within 60 days to achieve this goal of the Global Breast Cancer Initiative. Examples of innovative delivery of breast cancer diagnostics are telepathology and teleradiology, where pathology facilities exist, but there aren't enough pathologists using telepathology, and where teleradiology, where diagnostics exist, then teleradiology can expand the capacity by linking to specialty centers to read the mammograms. Now, moving on to treatment, a strong statement from the Global Task Force on Cancer Care and Control is that breast cancer is highly treatable with affordable therapies that result in the addition of many years of life. Pillar 3 of the Global Breast Cancer Initiative is comprehensive breast cancer management with a goal of 80% access to multimodality treatment without abandonment of this treatment and a successful return of the patient to the community following the treatment. Now, breast cancer treatment has gotten more and more complex as we better understand the molecular and the genetic changes that are unique to each single cancer. Our trends in breast cancer treatment are better targeting, individualized approaches, better outcomes. You have wonderful talks about this throughout this conference. So we need to tailor treatment to the individual cancer and the individual patient, and that involves increasingly complex diagnostics to better understand the proteins and the genes that are abnormal or changed or amplified that lead to each cancer. Now, another innovative method for delivering breast cancer care, we're calling optimal tasking, task shifting and top sharing. We know there aren't enough oncologists, enough radiologists, enough pathologists, enough surgeons and radiation oncologists in most countries of the world. And the notion that all cancer care needs to be provided by very highly specialized clinicians should be challenged. Non-specialty care doesn't necessarily report in poor outcomes if it's provided with training, supervision, and integration into the more specialized oncology care. So we can train primary and secondary care providers and facilities that don't necessarily have oncology specialists to provide at least certain portions of oncology care, as long as they're strongly linked to the specialty centers. We can better use community health workers, engaged patients, and clinical officers, less skilled health workers, to deliver at least some aspects of breast cancer care and follow-up. Here's an initiative that we've launched in the US through ASCO on improving access to cancer care in rural settings, where we have large regions where we don't have oncology specialist providers. We've picked one state, Montana, that's a very rural state with very few oncology specialty centers. And we are piloting a hub and spoke model. We're allowing cancer services and support to be provided, at least some of it at rural sites, without oncology specialists. We're creating cancer care delivery team at remote sites. We're supporting primary care physicians and advanced practice providers to provide the care. We're leveraging telehealth services in a hub and spoke model. And we're providing access to comprehensive survivorship care. Now, we're also creating infusion services and day hospitals with patient support out in those spokes without the primary oncologists being present, but with the support of the primary oncology team. So this is one of our ongoing initiatives within the US to better provide care directly where the patient is. ASCO is also strongly involved in improving the quality of care. And this is our new pilot in what we're calling APC4, ASCO Patient-Centered Cancer Care Certification. It's based off of medical home safety standards and chemo safety standards that were developed by ASCO and the Community Oncology Alliance. We call this our oncology medical home model. And parts of this model are patient engagement, availability and access to care, providing evidence-based care, promoting equitable and team-based care, improving quality, making sure we focus on the patient's goals of care, palliative and end-of-life discussions, and chemotherapy safety. This ongoing pilot is in the United States at 12 practices across 88 sites, and we have 2 of our insurance payers involved as well. A key part of quality care is practicing evidence-based medicine. ASCO has a number of guidelines for practice that are aimed at a high resource level. And we also attempt to work with the global oncology community to build evidence-based, economically feasible, and culturally appropriate resource stratified guidelines on targeting clinicians and policymakers. We've published resource stratified guidelines in cervical cancer, palliative care, colorectal cancer, and ovarian cancer, and will soon be publishing a metastatic breast cancer resource stratified guideline. Now, we at ASCO went to our international members and asked, how can ASCO best add value to you, your patients, and cancer care in your country? And key answers were access to essential drugs. This was number 1 across our international sites, but following quickly behind, we're helping in the development of registries and with pathologic diagnosis. So knowing that our members globally were asking for help with access to essential drugs, we actually held a stakeholder summit on access to essential cancer medicines at our ASCO annual meeting this past June, with stakeholders from across the globe. And we decided that our best effort at ASCO would be to partner in global access to oncology medicines. And here we've partnered with the International Union for Cancer Control's Access to Oncology Medicines, or ATOM Coalition. This coalition was just launched this past May at the World Health Assembly, with over 30 public and private sector partners, with the goal to increase access and availability of cancer medicines in low and middle income countries. The strategy is multi-sectoral, bringing together partners with different areas of expertise. And ASCO is a full partner in the coalition, with our expertise being in education, capacity building, quality care delivery, and monitoring. So here you see the strategy to improve the capacity of low and low middle income countries to receive and use cancer medicines. We're going to start with 5 to 10 countries and grow to 40% countries. We want to make available those drugs that are listed on the WHO's essential medicines list, generic, biosimilar, as well as innovative cancer medicines. You'll be interested, since this conference is on breast cancer, to hear that the initial focus will be on breast cancer, with plans to add prostate, cervical, lung, and colorectal and pediatric cancer. And an innovative strategy here is to secure voluntary licenses for some new medicines, expensive medicines that are still on patent, from biopharma. And we're creating a business model to interest pharma through voluntary licenses and the medicines patent pool. Now, again, since ASCO has a strong commitment and expertise in quality, we've also signed a memorandum of understanding with the World Health Organization this past June to improve access to quality cancer services as part of universal health coverage. And we have two outputs. Both are focused on quality. One is to prioritize and align indicators that can be used in WHO tools and ASCO activities, with a primary focus on breast cancer and palliative care. And output 2 will be to develop case studies as we use these tools with the WHO and ASCO activities to disseminate throughout our work. Just 2 more parts of the cancer care continuum to address survivorship. We know that once we're done with treatment, that cancer survivors have many issues. And we need to train expert patients, community health workers, nurses, and primary care providers to help us, the oncologists, to provide long-term emotional support, guidance and symptom management, and patient navigation. One innovative strategy that we developed in Seattle was creating a patient support group called Team Survivor Northwest to focus on exercise and fitness and healthy lifestyles for all cancer survivors. I'm the founder of this in 1995. It's still going strong all these years later. And it created a support group focused on healthy lifestyles where patients were helping themselves. We knew that with access to early detection and treatment, the majority of breast cancer patients could look forward to a long life after diagnosis and treatment, that healthy lifestyle choices could help prevent health and well-being of our survivors. And the goal of Team Survivor Northwest is to help patients take charge over factors which they have control over. In palliation, we know that palliation of pain and suffering is a basic human right. And GAPRI, the Global Access to Pain Relief, was formed as a partnership with UICC, the Union for International Cancer Control, the WHO, and the UN Office on Drugs and Crime, with the goal to make essential pain medicines universally available. Recommendations from GAPRI are to educate policymakers and others to change opioids policies and prescription regulations, and to put in place safe and effective management of pain medications and palliative care at primary and secondary care levels. This picture shows my colleague at the Uganda Cancer Institute showing a bottle of liquid morphine. This is how they dispense both inpatient and outpatient pain control in Uganda. They've gotten around some of the regulations and regulatory barriers by manufacturing the liquid morphine in Uganda. They've gotten around some of the issues of the inappropriate use of opioids by putting it in liquid form. It's harder to sell on the street in liquid form. And in a sense, they have a very innovative model on how they've been able to provide access to pain relief to cancer patients and others in Uganda. So I'll go back to this initial slide that I showed on strategies for improving breast cancer outcomes that came from the Global Task Force on Cancer Care and Control. Again, I hope I've shown you ways that we can be innovative and strategic in improving awareness of breast cancer as a curable disease to get patients to come in sooner when they feel a breast abnormality. I've shown you ways that we can integrate early detection programs into maternal child health, sexual and reproductive health, and HIV and AIDS programs. I hope I've convinced you that we need to augment our cancer registries so that we have evidence and data and we know if interventions that we're making work. A clear case for early detection is made by the UN, the WHO, all of us. We need to tailor therapies, which is increasingly complicated, but can be done to individual patients and cancers. We need to develop economically feasible, culturally appropriate, and evidence-based guidelines and stick to them. And we need to promote public advocacy for breast cancer prevention, detection, treatment, and research. So in conclusion, I also want to once again emphasize patients are our partners in improving breast cancer care. I created this Women's Empowerment Cancer Advocacy Network with many colleagues called We Can. The 2017 World Health Assembly Cancer Resolution made a strong statement that we need to continue fostering partnerships between government and civil society and build on the contribution of health-related non-governmental organizations and patient-related organizations. And these are pictures from We Can work and conferences in Kampala, Uganda, Kiev, Ukraine. And I think I'd like to close by saying that we can help empower, connect, and educate breast and cervical cancer patients to improve cancer outcomes globally. Thank you very much for your attention. Thank you for inviting me to speak. And let's work together to help improve the lives of our breast cancer patients.